The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Welcome to Albany County News. I'm Mary Rozak, the Director of Communications for Albany County. And in the next 30 minutes or so, we're going to be talking about something that's very serious, something that people may talk about or may not talk about. We're talking about mental health, mental illness, and May is Mental Health Awareness Month. So in advance of that, we have Dr. Steve Giordano, the Director of the Albany County Department of Mental Health. Welcome.
Thank you, Mary. It's good to be back.
It's good to have you back. And I know that, I start out by saying, mental health, it sounds innocuous enough, right? Mm-hmm. And yet, when we talk about mental health, we talk about, like 1 in 5 people really suffers from some kind of mental illness. And when I say mental illness, people don't want to talk about that. How do we break the cycle?
Well, you put it very well. Those are the two main issues that I think are worth talking about. One is the fact that mental illness in one way or another touches all of us. Mm-hmm. 1 in 5 Americans, adult Americans, we believe will be touched by a mental illness in the 12-month period coming up, and if not them, a family member. So it is close to all of us. And the second thing is the stigma that prevents us from having that kind of dialogue, and that kind of keeps it in a cupboard where we don't want to look at it.
You mentioned the word stigma because the national theme for 2018 is Cure Stigma. Mm-hmm. How do we do that? Talking is one thing, but how do we talk about mental illness?
Well, we take it as a mission in our department where we provide a range of services to try to talk to each person and their family members as if they were a whole person, not a person. We don't talk about people as if they're their diagnosis. We talk about people who have life challenges. We try to normalize, it's a funny way of putting it, normalizing their mental illness. We don't have stigma about diabetes or heart disease or cancer in the same kind of way. Mm-hmm. Yet in many ways, and Mental Health Awareness Month this month is about curing the stigma and talking about the health of the person as a whole person, their physical and their mental health. I always say they are us. It's easy to talk about those mentally ill people, but when you look at the numbers, and as we mentioned, 1 out of 5, it touches all of our lives, and we all, afraid to say, or maybe upset some viewers, we're all on the spectrum. We all suffer from different things at different points in our life, and none of us are protected necessarily from having it touch our lives.
Well, I don't think people think about it. I know there are 2 words, mental and health. And I know if we're going to the doctor and we're stepping on a scale, we know we're on a spectrum, right? We know we're a little overweight. We know we're exactly a little, right. Whatever. If we have our blood tested, maybe our cholesterol's high. That's one kind of thing. But when you think about mental health, nobody, you put it in an interesting way. We're on a spectrum with that as well.
Yeah. Well, there's no real good X-ray for mental health. Mm-hmm. There's no good blood test for mental health. So it is all about what our most private experiences, which many of us feel ashamed about sharing or talking about, or even admitting to ourselves. Mental health includes addiction. And addiction is often talked about in terms of people's denial about their addiction. We serve people with addiction and mental health, and what we find is interesting is some people will admit that they have an addiction, but they'll deny the fact that they have a mental illness, and vice versa, because people feel ashamed often that they're not what they think they should be, what the Facebook tells us we should be. Everyone's so happy on Facebook. Well, everyone's not so happy, and I think we know that because my work is is working with people who have a host of different challenges, but they're no different than you or I. They want the same things. They want meaningful relationships. They want jobs. They want recreation activities. So they are us.
Let's talk a little bit about the addiction component, because I think that there are some things that we know about and some things that we don't, right?
Yes.
So there's the addiction where there's the physical part, that drugs, can be addicted to drugs. We can be addicted to nicotine,
Sure.
smoking. We can be addicted to shopping. We can be addicted to the difference, other than the physical. What is the key? What is the key to that addiction?
Right. Well, compulsivity in terms of whatever the behavior, meaning that it's repeated to kind of calm certain inner anxiety. Those are the common threads. But it's interesting because addiction is used to describe all of those things. There's, I think, the technical aspect of addiction and what happens in your brain. And then there's the behavioral aspect of addiction, which is the compulsivity. Some of the things that we talked about, like tobacco and drugs, and we're even seeing social media, internet types of behavioral addictions, actually affects the brain in a similar way. There's a lot of research that's now showing that dopamine, which is a neurochemical, gets activated, and we crave it, and we do whatever allows the brain to release that. So, gambling, we know, for example, does that same thing to the brain that the drugs of abuse do. We know that checking your email every 5 minutes gives a little blast of dopamine to the brain. This is actually, it's a whole other show we should do on social.
So my brain, when I am stressing about checking all the emails, my brain is actually getting a charge out of it?
I think I was at the Proctor's Theater recently, and I was up in the balcony. I was looking down, and during intermission, there was a sea of people who were not sitting and actually interacting with one another. They were all watching their screens, and it was a frightening moment. We all make our own choices about that, but the less or more, and we want our kids to get off it. But there is evidence to suggest that it's increasingly affecting our brains in the same way. So addiction, my point simply is that there's behavioral aspect of addiction, which is the repetitive aspect, compulsive aspect, which usually calms an anxiety or something. We shop till we drop. And then there's what happens in the brain. No one wakes up and says, I want to become a drug addict or any kind of addict.
Right.
Some of these things, though, affect our brain in such a way that we begin then to crave that chemical, and so we ostracize and we stigmatize the heroin addict. But if you talk to some of these people, many of them started with pain medications prescribed by their doctors, for example. They are us again. These are people that they don't wake up, and no one wakes up in the morning and says, I want to throw my life away and become a drug addict.
Sure.
So there are some common threads between all of those.
Let's talk about, since we are talking about drugs, let's talk about something that's under your domain, and you talk about addiction. You talk about opioid. I know you and I talked very recently, and I have some numbers here. The opioid deaths in Albany County.
Yeah.
And it's hard to determine. We don't have solid numbers yet.
Correct.
For 2017. We don't have solid numbers completely for 2016.
That's correct.
Number one, first of all, why would that be?
Well, there's a number of reasons, I believe. In Albany County, we have a coroner system which works with multiple medical examiners in different hospitals. And what I've learned in the last few years is that all the different pathologists have different standards of reporting. So sometimes you'll see an autopsy report, for example, where the cause of death is respiratory arrest. Well, okay, that could have very well been, but the underlying cause was a heroin overdose. Some pathologists will list that as heroin overdose. Some will say respiratory arrest, and when it gets logged into the system, it underreports the data. But part of it also is that there are extensive toxicology reports that are done when someone dies under unexplained, unplanned circumstances, and those take months to finalize. So we're always...
Why does it take so long just the average, the lay person would say, why would that? Why would
I think
take
there's the volume of analysis that are being done in labs across the country, and there's the volume of deaths, and this has been a challenge across the country. The New York Times released opiate death data recently, and we're certain maybe up to 2015, 2016 gets a little vaguer, where 2017 is not done yet, and we're projecting into 2018. It's hard to capture the trend accurately because we're always behind. But suffice it to say, one death is too many, and we certainly have more than one in Albany County.
We do, and I know that, when I say the numbers that you and I talked about yesterday, from 2012 through to now, through 2017, 208 confirmed. And as I indicated earlier, you said that 2016 they still haven't completed, and 2017 is only the numbers that have come in are only partials.
That's right.
Some might say, yes, one death is too many, but 208, we're saying it's an epidemic, 208 throughout the county. I think what I'm getting to is your point that sometimes we think it's underreported due to different factors.
I think it's underreported due to different factors. But, we can't take much comfort in the fact, but I think it is a fact that there are parts of the country that are ravaged much more severely than we are. And again, one is too many, but there are counties in New York State, and there are counties across the nation that are really ravaged by what is accurately described as an epidemic. New York Times reported that the deaths last year from opiates confirmed across the country rival the number at the peak of the HIV epidemic. And if you remember, that's in the 60,000 range.
Wow.
You remember how concerned we were about that? We're there again.
Wow. What do you and the team, the Department of Mental Health, do for folks who maybe know someone or living with a family member, or someone's out on the street, a family member or someone? What do you do, and what kind of programs and services do you have for those impacted by addiction, and particularly for opioid addictions?
Yeah, well, it's a complicated endeavor because we touch the lives of people in many different ways. So we're a mental health department that treats addiction, and we also work with dozens of agencies in the community that specialize in one or both. So part of the role of the mental health department is to coordinate that whole effort. We probably work with 20 to 30 addiction programs in the community, as well as a dozen or more mental health programs. And there are levels of care that people require at different times in their life. So for example, we have a clinic, which is an outpatient clinic where people are healthy enough to be able to come to appointments on a regular basis to help them stay away from the drugs that they may have been struggling with in the past. But when someone's in the midst of a drug crisis, we're not the person for them. We direct them to some of our partners in the community, the detox programs, the rehab programs, inpatient and residential programs. And similarly with mental health, we run a mobile crisis team, as you know, and we touch 1,000 people's lives are touched each year. They all have a different story. They all have a different need. And part of our role is provide the care when we can, but get them to the appropriate level of care that they need if it's not going to be us to provide that. So on the street, we work very closely with local law enforcement, and we're starting to know people, familiar people who we've encountered over and over again, that we're trying to do prevention work with to get to them before they are in a crisis, to offer them connections to services before they are getting an EMS call to bring them into the hospital. Varying levels of success, but it's a constant shared partnership with our programs in the community.
A couple of things I know that are being done in Albany County in tandem with the health department. The Narcan trainings,
yes,
monthly.
Yes, we do. It's important to mention the health department. Dr. Whalen and I chair the opiate task force at County Executive McCoy's request, and the health department brings a whole set of public health skills to the table in terms of prevention, education, data analysis that complements what we do. Tell me again, what was the question?
The Narcan training.
Oh, yeah, the Narcan
First
training.
Tuesday of every month.
Yeah, so we have invited Catholic Charities into our building at 175 Green Street, and we sponsor the provision of this training, which is monthly to all comers, people who are suffering from addiction, family members, treatment providers, and they are trained in the administration of Narcan, which is an opiate overdose reversal drug.
Okay.
Which I have actually in my car, and I think the CDC was just recommending that everybody get trained in Narcan administration because it's a life-saving drug.
So you're trained in how to administer. Is it a needle? Is it a shot? What kind of?
There are two ways of administering this drug, intranasally and through a needle. We've had trainings on both, and as you might imagine, some people prefer the intranasal.
Sure.
Non-medical folks who are like, don't give me a needle. But it is a lifesaver, and we're seeing that some of our EMS providers, if they come upon someone with an unexplained, unresponsive kind of condition, they'll start with that drug to see if it's an opiate overdose, you'll get a response. If it's not, then you have to go on to something else. But it's a non-lethal, non-dangerous way to try to save someone's life.
So the training, people sign up for it in advance, or they just show up
They
on
can
the
just
first
show
Tuesday?
up. They can just show up.
Okay.
First Tuesday of every month, 11 o'clock, 175 Green Street, and both the health department and the mental health department advertise it on our website, which is albanycounty.com.
Yep, I've seen that on the website. So when people have gone through this training, what is it, about an hour?
Yeah, 45 minutes.
Okay. They go through the training, but they also walk out with one of these kits.
They do. They're given a broad education, quick education though, in what opiate overdose is and on how to intervene if necessary. And the drug administration is demonstrated. They're given a kit. There's some records of how many times this is administered by the people that we train. That's kept by our sponsored training agency, Catholic Charities, and it's pretty significant. There are folks that are using it all the time. We know that police and EMS are using Narcan on a daily basis.
I think I should probably make clear that there may be some people out there that say, wait a minute, people are walking out with a kit of some kind, and we're talking about opioids. Anything that's taken, this is not a drug that is going to give somebody a high.
No,
this is a reversal drug.
That's right. It actually has it's a benign drug that has no other effect for good or bad if it's not introduced to someone who's in the midst of an opiate overdose. And it's not a cure. It's a life-saving tool, just like CPR might be a life-saving tool, but you still need to go to the hospital, and you still need to get treated. And hopefully what we're trying to do is work with our hospitals to then hook those people up to treatment, or at least let them know about where treatment can be.
Sure. And once again, that is free. We're talking to Dr. Stephen Giordano, the director of the Albany County Department of Mental Health. Let's switch gears a little bit, something that you brought up, crisis intervention training.
Yeah.
And very recently, Albany, one of 4 across the country, Albany County, selected for a special advanced training.
Yeah,
Talk to me about that.
I'd love to. We're very proud of this fact. Backing up a moment, the county executive McCoy made a priority 3 or 4 years ago to maximize the work between law enforcement and mental health providers. And one of the ways that we're doing that is through crisis intervention team training. It goes by the acronym CIT training. It's an evidence-based, nationally recognized model that came out of Memphis, Tennessee in the 80s. We do this twice a year. To date, we've trained over 200 law enforcement officers, and I think it's really important. I appreciate the opportunity to just talk about this. Patrol officers, university police officers, correction officers, probation officers, and it's a 40-hour-a-week training, and it's about mental health, learning de-escalation techniques, and how to keep police officers and community members safe in their interactions on the street, which happen all the time. So someone somehow heard about the good work we're doing, and I'm very proud of that. We were selected by the Crisis Team International out of Memphis, along with Sanovian Pharmaceuticals, selected us, Miami, Chicago, and Columbus, Ohio, as 4 sites that were far enough along to provide advanced training to officers who have already graduated. So of our 218 or so graduates to date, we were able to bring 45 in just a few weeks ago for a full day advanced training. National folks came in, local partners, the Epilepsy Foundation, did a morning training on, again, increasing and enhancing the abilities of the police officer. We put a lot of demand on police officers to, you go into a situation.
They arrive on the scene of something. They don't know what they're encountering, right?
And they don't. And when someone's not responsive, it's easy to go in to police officer mode and control the situation mode. But what we've learned through these trainings with them is that a lot of other things can be going on in that moment. Someone could be in an epileptic moment or recovering from an epileptic seizure, which is part of what this training was about, or they could be experiencing a myriad of mental health problems that not immediately going into police officer control the scene mode can really benefit all the parties there. And so crisis intervention team training we're moving forward with. It's actually part of a larger initiative that the mental health department has been involved in for a number of years. Mentally ill people are disproportionately found in our jails and prisons. It's been many years of shrinking hospital resources across the nation and across the state. More mentally ill people on the street. More of them are getting arrested, sometimes unnecessarily. So our work with crisis intervention team training, a mobile crisis team, our jail diversion efforts in the city court.
Right, with the LEAD program.
The LEAD program, pre-arrest diversion. We have mental health workers in our jail, our reentry program for people coming out of jails and prisons. It's all designed to try to get people who are experiencing mental health challenges out of the criminal justice system when they were in it unnecessarily. It's not a get out of jail free card. Just because you're mentally ill doesn't mean you shouldn't face the consequences of your actions. But we see a lot of people repeatedly ending up in jail because there's nowhere else for them, and they keep stealing. Literally, it's like Les Miserables, or is that the one where they steal a loaf of bread? It's like continually getting arrested for things that they need treatment, not jail.
Are there the treatment options out there, or are we lacking in some of that as well?
Just in a meeting this morning where I was praising the diversion efforts of so many of our partners in the community and decrying the fact that there are increasingly fewer options for people. All of our services are pretty maxed out. And the metaphor we were using this morning was air traffic control. People need to get the treatment they need, but unfortunately, that treatment can only be for as long as they necessarily need it. That doesn't sound so odd, but for many years, people go in the hospital and they get a hospital stay of 20, 30 days maybe. Average is like 3 to 5 to 8 days now. You get in, get out, get hooked up to somebody in the community, continue the care, because there's someone waiting to get in. Our crisis units at the hospitals locally are jam-packed, and people will sit for maybe more than a day sometimes to get evaluated and then triaged into a hospital. We run outpatient programs, and we see people when they come out of the hospital. And we just, one of the new things that our mental health department recently did, since I know you're going to ask me, is we moved to a same-day access model. And that basically means you call us, as opposed to saying, we'll give you an appointment in 10 days and 20 days after that you'll see a psychiatrist. We tell people, come on in. We'll see you today. We'll triage the situation today. If we're the right provider, we'll start treatment today. If we're not, we'll hook you up. And
how's that working?
We're busy. As I often say when people ask me, how's mental health? going. I say business is good and that's bad. So
Okay.
business is good. And but again, when you're in it every day, it's all in a day's work. You never know you're going to encounter. But I'm convinced more than ever, they are us. These are our family members, our neighbors, our coworkers, and all of us can have a bad day, and all of us can experience symptoms of mental health problems. Doesn't always translate into a chronic mental illness. I think when you say mental illness, people think the major mental illnesses that persist over time, schizophrenia, bipolar disorder, serious, no doubt, but anxiety and depression are the most common reasons people seek mental health treatment, and we all experience those things at some point in our life.
Sure.
So getting back to your question before about how do you talk to people about it, you just do, and you normalize it, and you treat them as worthy individuals, even though they have anxiety and depression.
How do we make it so that your business is not so good, so that you're not, I mean, what can we be doing? Because you said we're all on the spectrum.
Yeah.
What can we be doing to ensuring that our mental health is good?
Yeah. Well, you go back to the theme this year. One of the themes is sound mind, sound body. And I think that what we're talking about so far, or mostly today, is our reaction to problems once they arise. I think part of the equation, to answer your last question, has to do with prevention and education. And what we've learned is the earlier you intervene in someone's life challenges around mental health, the better their prognosis is. But by earlier, you could say, well, when their symptoms first start developing, oftentimes because of stigma, people don't seek help. The earlier you can get to people, the better. But I'm actually even talking about childhood issues and prevention earlier on.
And we, through our Department of Children, Youth, and Families, do.
Exactly right. The mental health services for children and adolescents comes through that department, which we all partner very closely together. If they were here today, they would talk about what the science is showing us about adverse childhood experiences. The acronym is ACEs, and there's tools to examine how many of these adverse childhood experiences people have experienced, and not surprisingly, the higher you score in terms of the ACEs, the research is pretty clear. Not only are you more likely to experience mental health challenges down the road, but health problems as well. So when we're looking at adults now with heart disease and diabetes and all kinds of other challenges, and you give them this scale, this tool, the data is very clear. High scorers have more mind and body health problems down the road. So the answer to your question is to really intervene as best you can in the schools, with families, teaching them healthy lifestyle issues. The way to prevent, heart disease and diabetes, we know.
We need exercise. We need good nutrition. We need
good night's sleep.
Yeah. Okay.
All of those things, again, shouldn't surprise you, counteract the development and/or progression of depression or anxiety. So we're really focusing this month, Mental Health Awareness Month, on the whole person and their mental and physical well-being. The earlier you intervene, the better off people will be down the road. Some of the conditions we've mentioned are not curable. Schizophrenia is pretty much a lifelong illness. But we have great success in helping people live meaningful lives despite their illness once they get into treatment. Okay. Some of the illnesses that we talked about come and go. Sometimes people who have depression have it once in their life and they never have it again. So it's not always a chronic and persistent illness. Sometimes it is. But I think people are ashamed of not being perfect, so they don't talk about it with their loved ones. They don't ask for help when they could. I think men are notoriously worse at asking for help than women in general. But no one's really good at saying, I'm having a psychological problem. And so they wait and they let it get worse. And then we have to deal with the crisis situation rather than the earlier kind of intervention.
Well, we want to make sure that that people know where they can go to,
Yeah.
to find out more information. So, Dr. Steve Giordano, the director of the Albany County Department of Mental Health, and his team can be reached. Go to albanycounty.com, click on departments, and click on the Department of Mental Health. You can find out more about different programs that are going on, and certainly find out more also about the Narcan training. Thank you,
Oh,
Dr.
my
G.
pleasure. I always like to come and speak with you.
All right. Well, here's to good health and curing the stigma, hopefully.
Hear,
in May.
hear.
All right. I'm Mary Rozak, Director of Communications for Albany County. This is Albany County News. I'll see you again soon.